broadcasting now over to Vancouver for the next panel presentation as well. So I hope you all enjoyed the morning and had some learning and listening. I sure did. And then I hope you're able to enjoy the beautiful weather and have something to eat as well for lunch. Again, within here in Kelowna, there are 2 rooms running in the Skeena area, so please feel free to head over if you want to be those. But want to also welcome our panel for the afternoon. And I would like to hand it over to Marie Elsa from the UBC Health team, introduce herself and introduce the panel for the next plenary session. So thanks, come on in.
Lower this. Good afternoon, everyone. I hope everyone's digesting their food and was able to enjoy a nice lunch. I'm very excited. Well, I guess first introduce myself. My name's Marie Elsa Morency, and I'm the Okanagan Health Partnership Manager with UBC Health, a new role here in the Okanagan, really about bringing partnerships and partners together like we are exemplifying here today. I'm very excited to bring and introduce you this session on philosophy of building AI integration into the BC care system. I feel we all know this is a topic with excitement, with angst, maybe even anxiety, or excitement, all of the above, and nothing better than to bring the different perspectives of people in the landscape together to share their knowledge and wisdom and guidance. So without further ado, I'd love to introduce our moderator, Dr. Léa Parot. Léa is a professor in sustainability and the Dean Pro Tem in the IK Barber Faculty of Science. And I will pass it to Léa to further introduce herself and her panel, or the panelists to introduce themselves following that. Thank you, Léa.
Thank you, Marie Elsa. Is this on? Yeah, okay. We have an incredibly interesting topic to discuss today about the integration of AI into healthcare systems. It's such a rapidly evolving field with so many incredible opportunities, challenges, and potential concerns. And so I'm really pleased to be here with a panel of 4 experts who will be able to enlighten us a little bit on the subject, or maybe a lot. And I am going to start just by introducing letting each of them introduce themselves, take 2 to 3 minutes to tell us who you are and how you work in the field of AI and healthcare and that intersection. So I'll start over here with Michael.
Good afternoon. I'm Dr. Mike Partrick. I'm a radiologist at Kelowna General Hospital. I'm here as a potential clinical user, not as an AI expert at all. But this kind of dovetails into 2 other groups I belong to, which the BC Radiology Society is a representative of all radiologists in BC, and I'm on the AI committee for that. And also I'm a chief screening mammographer for Kelowna, and I'm on the AI committee for Screening Mammography BC. They're both brand new committees in the past, basically 1 to 2 months. So I'm just very interested to hopefully learn some things from this, because a lot of these questions dovetail exactly what the questions that we've already discussed in these other committees. So I'm interested to see how this afternoon goes.
Hi, everyone. My name is Angel Arnaud. I'm a surgical oncologist. I work in 3 health authorities, the Provincial Health Services Agency, Providence Healthcare, and also in Interior Health here in Kelowna. My role is administrative. In addition to my clinical role, I am the Chief Medical Informatics Officer at PHSA. And what that means is that I work with technology and data to actually drive and improve our healthcare system at all levels. So from the front line all the way up through to the back office and Ministry of Health level, we interact with a lot. So that's kind of my role in Provincial Health Services Agency, where I hold that role. It is, for those that are not familiar, a health authority that not only oversees provincial clinical programs, but it also does the supply chain, procurement, and legal services, digital services across the province. It also has clinical care delivery, such as with cancer and children's care. So my role in this panel today is as a clinician as well as administrator, as well as a scientist, integrating the AI tools that we have, whether they're coming from the research community or commercially bought, into real world workflows, applying them effectively and training people to use them properly. Yeah, and that's it. Thank you.
Thank you. My name is Rasika Rajapaksha. I'm a medical physicist at BC Cancer Kelowna. I have been with the BC Cancer for about 30 years now, and BC Cancer Kelowna almost over 25 years. So I have been actually, ever since I moved to Kelowna, I have been affiliated with the UBC, at the time Okanagan College, and then now UBC Okanagan. And I've done a lot of work on analytics in the past, and around 2018, I pivoted towards AI work. And I've been collaborating very heavily with the UBC Okanagan Computer Science Department in trying to understand the underlying workings of AI systems. Because some of the things we realized at the early stage is that the AI systems are actually developed by people who are mostly from engineering and technology side of things. And those people don't have the domain knowledge in healthcare or whatever the other area. So when they develop these systems, they don't really take into consideration some of the nuances in the field. So I recognized that early stages, and then I started to move on. And then we are working quite heavily in interrogating some of the AI systems, and also trying to develop AI systems ourselves, and to meet the real needs of the healthcare system, particularly in cancer care. So I'm pretty sure I will be able to elaborate some of those things as we move along. And I'm also a faculty member here, adjunct faculty member here at the UBC Okanagan in the computer science department.
Great, thank you. My name is Raymond Lawrence. I'm a professor of computer science here at UBC Okanagan. I'm also the department head for computer science, mathematics, physics, and statistics. All those disciplines have a role to play in AI and data science. I guess I'm here to be somewhat of the technical side, and AI is a massive field. I'll answer questions if I can related to that. My key area of research did not start in AI. I'm a database person, which means how do you collect data? How do you integrate it in useful ways? How do you do analysis? How do you get the right data to the right people to make the decision at the right time? That's essentially what my research has done. I also have my own company. I've done consulting for Fortune 500 companies related to data integration. And the last few years, everything in computer science has moved to AI, as have I moved to AI on the data-driven side. And one of my aspects is working on AI and how it impacts education. Just like healthcare, education is going to be fundamentally changed with the AI, the new technologies in AI. And I'm definitely really trying to be on the forefront on how that impacts us at UBC and beyond. Thank you.
Thank you, Raymond, Rasika, Angel, and Mike. I'm going to start us out with the first question that I think I'm going to ask Angel to answer first, if you don't mind. And it is, what do you see as the biggest opportunities for AI in healthcare?
Thanks so much. So I will tell you that all over the world, there are some common themes that are challenges that are coming through in healthcare delivery that could really take advantage of the technology as it pertains to AI. So first of all, I think clinicians and really any industry, I think workers in any industry now are facing massive amounts of data. And the data is coming at you with a very, very strong force. And it's at the point where I think any human doesn't have the ability to assimilate all that data, take advantage of all that data. We're in an age where there is data on everything. And it would be a real shame if we couldn't take advantage of that, because we can create insights that we otherwise wouldn't have been able to get. We can actually practice medicine a better way. Currently, without data, we're practicing as if we're blind, and now you have data, and it's really important to take advantage of that. So, but within our limitations as a human, I don't think we can have an effective way to assimilate all that data, synthesize it, and and bring it up to a point where it's actually able to drive the decisions that we make every day in healthcare. So that's definitely one thing that AI can help, is to really synthesize all that data for us beyond the human capacity. The second thing I think that's an opportunity is we're also at an age where burnout and administrative burden is at its highest level. I think in our effort to digitize our workflows, our information systems, our electronic medical records, we don't have the ability to, other than the healthcare providers themselves, to be the ones entering the data. So the healthcare providers have all of a sudden become data entry clerks for massive amounts of data into systems, and they are burning out. Yet at the same time, the demand for the quality of healthcare, the demands of the patient are also increasing. So healthcare providers, I think, are stretched very, very thin, and there's a significant amount of burnout. If you ask any healthcare society or organization, burnout rates are in the 50% range. What does that mean? That means that people are not productive, they're going to make mistakes, they're going to retire earlier, and there's a shortage of providers. And so that's the other thing. I think if AI can help with reducing the administrative burden, if AI can increase the productivity and efficiency of the healthcare provider without removing the empathy and compassion component, because you're actually allowing the providers to concentrate on things they do best, which is to be empathetic and compassionate and focus on the patient rather than on the data collection piece and the administration piece, then I think the healthcare system would be in a much better place. So those are the two, I think, challenges that are right for AI to address.
That's super interesting. And I'm going to ask Raymond if he would like to follow up on that as our data person on the panel.
Sure, thank you. I actually think that's what's exciting about AI. If you ask yourself, if you're a healthcare provider, what would you rather be doing right now? Filling in a whole bunch of data entry forms or caring for the patients and making an impact on people's lives? So this is an opportunity to reimagine some of the processes that's happening in our healthcare system, all the way up and down that whole chain. Because hopefully, and this is hope, it's still going to take us a while to get to that place, but maybe some of those low-level tasks really do get automated. And then you do spend less time on data entry and more time where it matters, which is in patient care. In my own field in computer science, it's up in the air to determine how AI is going to impact that. A lot of our graduates are worried that, is there going to be any software development jobs anymore because AI is going to automate a lot of that work? And it may very well do that, but it may also leave the very much more interesting work, and not the low-level programming, but the more higher-end skills. That is what we want to train our students to do anyways. So I'm kind of optimistic on what's possible with AI, but it's not going to be easy to get there. The other part is that you also have a vision for personalized care. One thing that technology might allow us to do at scale is to really support individuals where they're at. And that is also an opportunity that we might be able to use AI to do. Thank you.
Sure. So I think I want to sort of follow up on the comments that both Angel and Raymond made. In particularly in health, I work quite a bit of work in early detection of cancer and cancer screening, and both lung and breast screening. In that, one example would be breast cancer screening program that we have in BC is the very first in Canada. And then we provide about 250,000 screening mammograms a year. And that's a lot of data. And they're done across the province, but sometimes the radiologists, I mean, I will let Mike to comment on this because he's one of the radiologists who read these things. And is it possible, because when we get about 1,000 women going for screening, they find abnormalities about 100 of them. And out of those 100, we only find about 5 to 6 cancers, right? So that means out of those 100, there's 190 some women would have to go through some extra additional workup, and that's provide, that makes them very anxious, and then also it's a heavy cost to the healthcare system. If we can use the AI to actually identify these things, and we can cut down the cost, we can help the anxiety of the people, and so there's a big gain to be made, particularly in early detection of cancer and other diseases, I believe. And then on top of that, I want to also comment about the place that BC with respect to the AI. And I strongly believe that BC as a provincially provided care system, we have a very good data. And when we want to develop AI systems, we don't just want to have one piece of data. For example, I do most of the work on computer vision or medical imaging work. We don't just having a medical image is not going to help. We want to know what happened to this person 5 to 10 years down the road so that we can train the AI algorithm to identify the features in these images to predict what is going to happen to them. And luckily in BC, we have this data and it's very precious. And then that's why I've been working on the data for the last 12 years, about 15 years. And I see great advantage here in BC to actually for us to innovate in AI and actually apply. And on top of that, we have very diverse ethnic population in BC. And sometimes when these AI companies come up with the AI algorithm, they are trained on data from a very homogeneous ethnic groups. And we have found that we will probably discuss later that very interesting characteristic that AI does sometimes. And it pick up things that we don't know what it is picking up. So we have that advantage of this wealth of very good data in BC. So I am very optimistic that we can actually improve healthcare and reduce costs. And if we take the innovation within ourselves first, and otherwise it will be imposed on us by other institutions and other interested parties that may not be the best interest for the people of BC. Thank you.
Thank you. Mike, what do you see as the big opportunities?
Yes, I just maybe answer Razika's question there about AI in screening mammography. We're actually looking, there's one program that has been studied that's out there and it's been starting to get incorporated in a couple sites. And it's increasing that cancer detection rate, what he's talking about, from 5 per thousand to 6.8 per thousand. So it's picking up 1.8 per thousand more, but I don't believe it's dropping the callback rate, which to me would be ideal if you can increase the detection rate but drop the recall rate, because it's the recalls, they're not unnecessary recalls, but in the end they turn out to be benign. As Razika said, the patient has to go through a lot of anxiety and stress about all these different exams, possibly biopsy. If we can drop that, that would be a lot better. The main question about the biggest opportunities, and this has come up in the other committees that I'm on as well. All of healthcare is plagued by understaffing. Can somehow we improve efficiency of the system so that less staff can do more? Sort of similar to what was brought up earlier. Can it help diagnostic accuracy as acting as sort of a second reader? Can it provide a broader range of alternate diagnoses in case there's something really rare that you maybe haven't seen before, but AI can maybe bring it up or at least mention it for something to at least to look into? And can it help with certain tasks that, again, like what you're talking about, data entry, but we do a lot of measurements of masses, nodules, blood vessel diameters, things like that. We do that manually ourselves. And same thing, if we can incorporate something that would help with that, that would definitely improve our efficiency. Even things like speech recognition when we're doing a report. The current systems out there are for medical reporting are not that great. And so we're hoping that that's going to help with speech recognition software. But even things like helping with scheduling of techs and physicians, and also helping technologists when they're doing a certain test, like an MRI. It's not just one button they push and they get a test. There's many decisions to be made about how to run the scan or what you're looking for. Can AI, and that is, I think, beginning to be incorporated in some of the new scanners. We have these 2 new MRIs that do have some AI in the background, but I think it's just at the very early stages. So it'll be very interesting to see where that all leads.
That's really interesting. Thank you, Mike. I've heard all of you talk about opportunities in relation to data processing and some of the more remedial data entry tasks. Nobody's talked about the family physician. Are we going to get to a point, maybe this is a Raymond question. When is the day when your family physician is an artificially intelligent natural language processing entity? Or is that the thing that keeps you up at night?
Well, that's not an easy question to answer. I think over time, AI will assist your physician, your healthcare provider. But I think a more interesting question is, are people going to be comfortable if AI was your only healthcare provider? So it's not just the technology, it's the human factor as well. I think many people would feel better that AI is doing an assisting role, not the primary role. Well, your healthcare provider, your family physician is there, someone to talk to, but the AI might assist them on maybe some technical knowledge or be able to provide some recall that they might not have. Because I think that would take a time before most people would be comfortable having an AI or a robot or however you want to think about while that technology is manifested physically as their primary healthcare source. So that's a good technical question. I can't answer for you when that will actually happen because we're not exactly sure how quickly AI will progress from where it is right now. So I take it we're going to question number 2, which is our fears we have related to AI. So I'll continue on that. My fear number 1 would be that we don't engage with AI at all. You can't put your head in the sand. This is not a moment in time where you say, this is going to pass by and I'm going to be all good. This is like the computer revolution. This is like the internet revolution. This is like when your smartphone came. Looking back, if you did not decide to go on that technology, then you would be left behind. That's where we're going to be with AI as well. So fear number 1 is not participating at all. Fear number 2 would be participating in a way that is not thoughtful, especially in the healthcare field. We're not in the tech field where you want to move fast and break things because these are people. They're not things that you want to break on a technology side. So things that are rushed, just picking a vendor solution and buying it and deploying it and think it's magically going to work for your context is not where you want to be. This does take hard work as a group, as a collective, to understand the context on how you want to apply AI into your particular area. So you can't deny that AI is there. That's fear number 1. Fear number 2 is don't rush to do it. Make sure you think about it thoughtfully because this is not going to be just a one-year thing. This is going to be a long-term progress that we're going to go through. Thanks.
I can add to it or you can go. Okay. So I just wanted to add to your comment about the family physician. So there's no question. I agree with Raymond that, if we're planning properly, we need to make sure all the safety checks are there before we let AI be autonomous. And there's a lot of regulatory and responsible use training that we have to do for everybody, including the people that the AI are going to be potentially taking over from, and the people that are on the recipient side of the AI. So there has to be a little bit more of a culture and safety checks before we just let AI take over. And in the meantime, there is definitely, I think, no question that the human has to stay in the loop. There's definitely human oversight. We should have human oversight right now on almost everything in AI that has a clinical impact or direct impact to patient care. Because we're still in the early stages of AI, we don't have enough necessarily data and effectiveness testing on the AI and safety monitoring that is we can rely on without human oversight. But if you think about, it's the same idea in my mind like an autonomous driving car. Right now, we're in the early stages of that. And I don't think any of us will go into an autonomous car without being a bit scared. And we are not using that in routine, routinely in this world yet. but just slowly by slowly. Right now, you are relying on your car to park for you, for example, and that's now becoming more acceptable. With time, I do believe that the society will, once we have a whole bunch of governance structures and safety checks in place and the culture changes and more reliant on AI, more and more demonstration of the lack of harm potentially from AI, there's going to be a little bit more comfort and more reliance on AI. But it will take time, like Raymond said. I don't think it's impossible. The second thing I wanted to say is that everything is relative in terms of risk. When we're talking about using AI, let's say, as a family physician or as a chatbot guiding you with treatment recommendations, if you're in a society or in a country or in a system where you don't have family doctors, where you don't have nurse practitioners, where you don't have a good healthcare system, or you do and you can't access it, maybe AI is the in-between solution where, sometimes I read reports like if you're in a place where there's no radiologist in the middle of the night, is it okay to use AI to read your x-rays? It's not great if you have a human there, but if you don't, is it better than nothing? And I think it's the relative risk that I think people are starting to think about when they're talking about whether AI should or should not do certain things that needs to be taken into consideration. Finally, I just want to say, in terms of my fears, I agree with you, Raymond, in terms of some of the fears that you mentioned. Definitely, we can't just put our head in the sand and pretend it's not happening. But my biggest fear is that it's happening very fast and it is outpacing our ability in the healthcare system to come up with the safety checks and the governance frameworks to catch up to it. And before you know it, it's going to be ubiquitous and everybody's going to use it, and it's hard to manage. And so that's what keeps me up at night. The other thing that keeps me up at night is, how do you train in the healthcare system? How do you train clinicians to evaluate AI and to critically think about whether AI outputs are safe or not safe in an age where a lot of them are starting to rely on AI? So there's a fear that students, medical students, nursing students are starting to potentially rely on AI for so many things that they're losing that clinical intuition, that critical decision making, that all of the things that they need to judge whether an AI output is sound or accurate. They're losing all that because they are relying on AI. So that's my fear, is you almost have to have people well trained in healthcare in their domain, and then you could slap on AI so that they can evaluate whether it's good or bad. Kind of like when I was a resident way back when, or a medical student, and for something like appendicitis, it was a clinical diagnosis. You had to, know some of the signs and features, and you can make that diagnosis clinically. And then some way halfway through my residency, it was, oh, why bother? Just get a CT scan, right? Just get a CT scan. Don't think. Don't even bother trying to, understand whether this person does or doesn't have appendicitis. Just get a CT scan. And so, or if somebody's having symptoms of a stroke, oh, just get a CT scan of the head, and that will make your diagnosis. Don't need to go through that whole process of trying to do the clinical intuition. And so I'm worried about that. And so how do we train our future providers to still have the clinical knowledge while they're relying on AI? Oh, sorry, Rasika.
So I wanted to mention my number one fear, which is I'm a bit worried about, and it kind of goes along with some of the discussion we had already about not getting into the AI particularly, and then not just to getting involved in it, but it being very actively involved in it. Because my concern is that AI, if we don't do that, not just us in Canada, in BC, but the rest of the world, the couple of big tech companies is going to take it over. That's my biggest fear. Just to give you an example, this morning, my phone came along and said, well, you complained last night and said, do you want to upgrade? I just ignored it this morning and said, oh, what the hell? Upgraded it. And all of a sudden, I can find my apps where they are. They change the colors. I didn't even know how to change it back. Like, do you want your health AI to be controlled by companies like this? No, I don't want to be. I don't know about you, right? So that's my main fear about AI. We want to democratize the AI. We don't want, particularly with what's happening in the US right now, we do not want to be controlled by AI systems that are controlled by different countries. And so I think that's where we have been. This wasn't the reason that we have been doing a lot of work in AI, but I think this become more emphasizing now. So that's my main fear. And then the second one is related to what Angel was mentioning about the interaction of human-computer interaction. It's a field that computer science is working on. How would human behavior changes when computers they're interacting with humans? So for example, in breast cancer detection, we use AI. Sometimes, the radiologist may go through the mammograms and decide what they can see, and then turn on the AI, and then say, oh, have I missed anything, right? Or they can look at the AI first, and then see whether they're good or bad. So if they do that, their behavior, their performance may be different. So these are the kind of things we need to evaluate. So I'm worried about some of those things by just implementing this AI system, which we discussed already, that some sites in BC are using this AI, and we don't know how they're using it. So how this is going to impact, we will eventually evaluate it, because that's a good part I mentioned to you about BC systems, health systems. We track everything. We have the data, what happened. So we can go back a year or two later, did improve or worsen the situation. So we can look at these things, right? But those are the two main fears I have with respect to the AI in healthcare. Thank you.
Thank you. Mike, do you want to add to that? What are your biggest fears?
Yeah, sure. Very similar to what has been brought up. Some things that have come up before regarding this. There's almost a desire, it's almost like a fear of not adopting it soon enough, but we don't know how to proceed in terms of, like, at the clinical level. Has it been studied enough? Which program is better? I mean, there's more studies are coming out now, but on the ground, we're just not sure, because we're not mathematicians or computer science people. We don't know how to evaluate it. We don't know how to incorporate it into the practice. We don't know when to, there's all those kind of fears. And a couple of other things even was brought up, when we're doing a report, do we have to declare on the report that this has been read by AI or assisted by AI or solely read by AI, or do we have to declare that to the patients, or are they going to be expecting it anyway? And then another thing that's brought up was, is there an environmental cost to AI being in healthcare, just with the more computer processing, and there's some talk about the environmental impacts of the computer processing and high energy demand too. So those are a few of the questions that we had.
Thank you, Mike. Your answer leads well into the next question that I have, which is, from your perspective, what barriers must we overcome to realize the benefits, the positive benefits of AI in the BC healthcare system?
Yeah, so it's sort of similar. It's kind of, I think there's a bit of an inertia of adopting new technology in a way. We generally, when we're assessing a new piece of technology, we wait for various different studies, and has to be clinically tested and things like that. And I think that there's a sense of overwhelm to a certain degree of, again, what I was saying before, how do we adopt it, and when should we adopt it? And same with, yeah, so when when there's different systems out there, can they be analyzed quickly enough so that if they're effective, then we can adopt them? And how do we, again, as clinicians, how do we choose the correct system or the correct AI? And in addition, should the entire province adopt the same processes so everyone's working with the same systems?
Thank you. Angel, do you want to add to that?
Sure, thank you. So two big barriers in my mind. Number one relates to data. So as Rasika and Raymond were talking about, data is the most important thing when it comes to AI. And yeah, in BC, we have a lot of data, but it's not all accessible. Maybe in imaging it is, but nothing else. And I think part of the reason why it's so important to have AI ready data, accessible data for people that are training models or developing models. It's important to make sure that we have the ability to validate the models that have been trained on other sources of data, so that when we actually decide whether or not the AI model will work in our population, that we can actually confirm that. And without our own data, we are unable to test that. So that very, very important is to have access for data for those that are not just developing models, but trying to apply the models and therefore need to validate the models before they deployed into clinical practice. Secondly is, I just don't know if we in healthcare are nimble enough to actually ride the waves of AI. So, in order to deploy AI, first of all, there's new solutions coming out all the time. You got to be really quick in terms of figuring out where it's best applied and which solution is best and what are the safety measures and how to continuously monitor the AI and measure and evaluate and then ditch it if it's not good and replace it with something else. That kind of nimble approach to implementing solutions like in any other private industry where, if you either move quickly or you will fail or fall behind. We just don't have that culture in healthcare. And I believe that everything takes forever. And the old way of testing solutions when we do clinical trials, for example, for drugs or for drugs, for example, it takes on average, 15, 17 years before something is coming out from a lab all the way into becoming a pharmaceutical drug in the market. And we just don't have that kind of time to do the rigorous testing. We have to be better and faster and more efficient at the way we test out different solutions, because it's coming at us at a very, very fast rate. And unless we're able to, quickly monitor and evaluate these solutions, they're going to be deployed in an irresponsible and unsafe way. That's my feeling.
Do you see any ways to be faster?
Yeah, so I think number one, you have to change the culture. In healthcare, we rely on randomized trials, which, a lot of money, a lot of investment, a high failure rate, requiring accrual. You got to be very smart about designing new ways of effectiveness testing, comparative analysis trials in the real world. You have to develop ways to use real world data, not just sort of observational data from clinical data. So that's kind of, I think, new designs of trials, new ways of incorporating data. Yeah. That's basically it.
Thank you. Rasika, do you want to add?
As a challenge, yes, I think I just want to follow up on the comments made already, in particularly about the talent, AI talent that we need in healthcare. That's one of the things I've been thinking about for a while now, and it kind of comes along with this. It's funny that I looked at here and then, the two doctors sat on that side, the mathematics people sat on this side. So it's like this actually exemplifies my thought I wanted to convey to you. The computer science and engineering people who are working on AI systems, they don't understand the domain knowledge. They know how to, they're told to do this, they will do it, but they don't know what exactly have to be done, what need to be covered. So that's one of the limitations on their side. And then the medical side, they don't understand the technical details of AI. So we need to have a bridge. And the way I've been thinking about this is that usually in medical field, they usually use the system one thinking. In system one thinking, they look at a problem, they have a solution right away. Sometimes they will have a hard time explaining to somebody else what was the thinking process that went into. And I remember one particular example with the radiologist in Victoria. I was reviewing some mammograms, and he said, here's a cancer. I asked him, why is it a cancer? Like, tell me, why do you say it's a cancer? He said, it's a cancer. And I realized that he can't explain exactly the specific detail that his underlying memory or thinking process has decided. Maybe Mike can comment on this one, right? So they use that system one thinking, and that's what the thinking process that we developed at early stages for our evolution. And later on, we came with the system two thinking, where the mathematical thinking process, where we logically step by step make thinking, right? So that's what is usually used for AI system development and testing. And when you apply to the medical field, for example, and you need to understand what are the problems, what are the issues that needed to be asked. So it's when we ask questions from the people in healthcare, sometimes you have to be very, very mindful about how you ask the question from them. Okay, what do they need to know? Right? Sometimes they may not explain it to you. They may explain it to you in the way they understand, but that may not very well fit to model your AI system. So it's very important for us to actually train AI engineers and machine learning engineers in coming, have a very good background in model design, but also understand the language the healthcare system uses and the healthcare professionals use it. And that way they can ask very specific questions. If you have an AI model that needed to be implemented, they understand these things, they know the domain knowledge, they will go to the users, the healthcare professionals, doctors or radiologists, whoever it is, and they can ask targeted questions. And they may not get the answer, they can continue to ask the questions until they get the right answers so that they can actually design the testing. So I think that's the most important challenge that I think we are facing right now to implement the AI. But I think it's slowly, and that's one of the things we have been doing with the computer science department. And in particularly, we have these computer science students who are doing their master's degree actually embedded in BC Cancer. So they don't do their research here. They are embedded in the BC Cancer. They are employees of BC Cancer. We get them to work with the clinicians so that they can understand how things are working in healthcare. I think that's one of the major sort of challenges I see that people are not seem to be really thinking about in the particularly the educational area, how to train the talent. And that's really important to build the talent, right? And Canada has been very good in early stages of AI. I mean, last year, this year, the Nobel Prize for Physics, I'm a physicist, so I'm happy to talk about it, was given for AI, right? For Jeffrey Hinton. So we have been very, very leading country when it comes to AI early stage development. And why can't we take it and then look at the opportunities and train our people? And so that we can be continuously lead the AI, particularly at least into healthcare, is what I think. Yeah, so a sort of challenge that we are really trying to address. Thank you.
Great, thank you. I would have to basically echo what everyone has said here. There's a process challenge, being able to adopt technology and adopt it at pace. And there's also getting the right people that are trained to work in AI and healthcare, that bridge that you mentioned. It's something that our department's really interested in. Rasika mentioned that we have master's students embedded in BC Cancer, because you really need somebody who understands the technology, but has also the expertise in the domain, in the context. And having those sort of relationships between universities and healthcare is definitely very beneficial. I just want to mention, just to put it in context, the scope and the speed of this change. While we're talking, probably a new AI model has been developed, or many since we've been talking, just in this period of time. Compared to other technologies that you could imagine, deploying a new computer system, those don't change as quickly as this field is changing. A new scanner, or a new CT scanner or MRI device, you have a pretty good idea when you deploy and upgrade what that looks like and the timeframes involved. But AI in the last year has changed so rapidly that you might have started an experiment to see if this would make sense for your continual process now, and it's out of date before in a month when you were doing it. And so it's not just healthcare, I would say, that's having a hard time adapting. It's everybody in every industry, but the ones that definitely have to have a more measured process, it's even more of a cultural change because they're not used to moving that fast. But I would say almost all of our industries, universities included, we're all struggling to keep pace with the rapid changes in AI and what that means. But once again, that doesn't mean we can hide from it, but we just got to figure out what that looks like on a case-by-case basis as we go. So yeah, thanks.
Thank you. Both of you have spoken about the opportunities to work together in the training space And so I think I'll pose the question starting with Mike about what other opportunities do you see for alignment across sectors?
Yeah, no, I agree. I think I do think that this can spur on greater collaboration between local researchers and people on the ground in clinical medicine. And as been mentioned before, we rely a lot on international research. It can take years and years to come up with results and years from there to incorporate. But with all this happening so quickly, we need to have more expertise aiding us in incorporating AI and what systems to use and things like that. And I think that the new Jim Pattison Center might have a bit of a role in there, because I think that they're going to allow greater contact between researchers and clinicians. So hopefully that they'll be able to help with some of these things. I was also wondering, because there was a question about Ministry of Health, like, is the Ministry of Health going to be mandating the use in certain situations? And if so, are they going to fund? That's always the question, is, you know, how do you get funding to incorporate new technology? So.
Thanks. So I think like many other new transformations in the world, what makes something sustain is that if you can link what the funder, which is the Ministry of Health, funder wants to fund, the investor or the funder, with what the the provider of the healthcare delivery system, the physicians and the nurses, what they see as problems that are worth solving, with the developers and the solutioners, so the researchers, the AI developers, with the implementers, so people that are actually going to make it happen on the ground, with what the patients actually find meaningful. So that whole sort of connection between all these different players in the healthcare system, there needs to be a circle drawn between all of them. Because right now what's happening is that we are learning a bit, every role has their different perspective on where and niche part in terms of what role they play in the AI system, whether you're a creator, developer, implementer, embedder, that kind of thing. But everybody has their unique role, and everybody's trying to learn a bit about what the other roles want, and what language, to Rasika's point, how to speak to the other roles to try and figure out what's the right path. But nobody's actually bringing it all together. And so we should all technically be in the same room, including the ministry folk, because ultimately a solution is not going to sustain or be lasting if it's not going to be funded. A solution is not going to last if it's not going to be implemented. A solution is not going to last if a patient doesn't find it helpful. So the whole thing needs to be connected, and it would be really great if we all have the same conversations with regard to what's the valuable problems to fix and fund, and who are the people to do it, and everybody just try and help each other solve common goals. And I don't know how to do that right now because our healthcare system is so fragmented and dispersed in some ways. At the same time, though, we are better than other non-publicly funded health systems because we do have the ultimate funder, which is the federal government. And so there is an opportunity in publicly funded health systems like Canada and in UK, for example, Australia, where you can have common shared goals. It's just a matter of bringing everybody together. It would be really nice if all of Canada came together, but that's another story. Thanks.
Thank you. Do either of you want to add to the question of how do we align across sectors?
I think what Angel mentioned about bringing everybody into the table or the room is the way to go. And again, I don't know how to do it either, so I can't try to do it in a very easy, simple way. I have the sort of the academic background. I work with the clinician, for example. Mike was was in the supervisory committee of a master's students in computer science who was building an AI system. So what I try to do is to bring in the clinical people. I go reach out to them and say, I'm working on this project. I'm interested in solving this problem, and I don't have the clinical knowledge. Would you be able to come and help us out? And that's how I reach. And again, I don't sort of go beyond that point. It's basically, as a researcher, I'm mostly working as a researcher for developing AI systems and developing techniques to interrogate AI systems, and then also how to do the testing. So that's where my work is. So I'm not really sure how to go about coming up with the ministry to fund it. The way I think is that if we find the right good problem that needed to be solved, and if you find a good solution, hopefully it will be funded. So that's the philosophy I go with in that part of it. So I think so there's a lot of opportunity for us to actually do this. And again, to me, it's very exciting. It is a little fear, but there is also excitement because I think AI has a huge value there. But on top of that, but there is risk of actually going it very fast, particularly. And I'm going to give you one example that we just recently encountered or found. The medical images contain the ethnicity information. And there have been some work done in the past. We were not quite sure about that. We took one particular example and we looked at that. And then not only we were able to train an AI model to detect 3 ethnicities in BC. Not extremely high accuracy, but way better than the random choice. And then we did some interrogation. The computer science master student, he did that again. I mentioned, and I had to spend about almost a year to train her about the domain knowledge. So that's where I think this issue that I face this day to day, because in order for computer science student, for me to supervise a computer science student to go and do this particular project, I need to give them right background, right? So that's where I sometimes get them involved in the clinicians. And what we found after that, we did some what we called ablation studies. We did some experimentation, and we realized that AI is actually using the size and shape of certain parts of that image. And we were able to prove that. And we know how to measure these things. We do these things, but we never use them for these kind of purposes. So that's what one of my fears of going past in AI is that if we don't really understand what exactly AI is using, we do not know what would be the answer. But on the other hand, we also talk about the concern about the explainability, right? There is a concern about it too, but also in healthcare, I think it's a sort of a different it takes a different shape. For example, I had to explain this to, again, another computer science student. I asked that student when we were talking about this, I said, you go to a GP, you have a concern, and the doctor will ask you a whole bunch of questions. And at the end, they might ask you to go do a test, blood test or medical imaging test, or they may decide, okay, you may have this problem and give you a medicine. And now you're going to turn around and ask the doctor, which question did you use? Which answers that I gave you actually made you make the diagnosis? We never question that from the medical people, right? So why are we so concerned about AI being totally explainable? Like, we can explain humans. So again, there are things that we need to be concerned about, but it's not to say that we don't have to be completely ignorant about it. But we need to go in this with the open mind and understanding how these AI systems work and test it appropriately for the use case scenario.
Oh, really interesting. I'm going to switch gears just a little bit with a final question, which is, how do you see us using AI to reduce inequalities, especially for addressing healthcare needs in rural, remote, and Indigenous communities? I don't know who wants to start with that one.
Yeah, so similar, it was brought up a bit earlier about can AI act as an initial interpreter? So, for example, if there's a small community, can there be some kind of a smart X-ray unit or smart ultrasound unit without like a physician on site or maybe even a technologist, but someone at least trained in how to take the pictures, but then the AI will interpret it. So that could bring imaging to multiple, smaller, more widespread communities for sure. And can that somehow dovetail into telehealth as well? So again, can AI be the initial reader? Somehow are they tagged to somebody sitting in Vancouver, something like that, that can help with the human side. So that's the main thing I was thinking of is being able to bring potentially some, from my perspective, imaging to smaller communities.
Yeah, I agree. I think that's the main thing. And it really comes down to, I think what we all are kind of implying in our answers is that, yeah, there's a requirement to make sure that we test out the accuracy, effectiveness, and the safety of AI solutions. But if you're in, it's all relative. If you are in the middle of nowhere and there's no access to anything, this is definitely better than nothing. And it actually is, if you look at it, all the studies that show that the AI, whatever it is, as interpretation or the AI clinical diagnosis or whatever, all these studies that have shown that it is actually more accurate than the human, which is not 100% accurate all the time. And so why are we worried? Why are we worried about a technology that is actually performing better in objective studies compared to the human? Why is it like that? And I think part of the issue is that right now we still don't have a solution as to who to blame if something bad were to happen. And I think that's why there is a hesitation in using technology. But certainly, I think we do this. I mean, for when you're on call and you're in the middle of nowhere and there's a resident who is there taking care of the population. That resident has not gotten their licensure to practice independently, but they're out there and they're doing a good job because there is nothing else out there to provide service. And so that's the way I think about AI, is it's all relative. In terms of helping the rural and Indigenous communities, I think it goes back to the data piece. If we are able to deploy AI into the rural communities or Indigenous populations or minority populations where we don't have much data on them, and where certainly most of the AI tools have not been tested on them or trained on them, then at least that's an excuse to get data from these minority groups and smaller groups so that we can actually make our AI models more generalizable. So that would be, I think, a really good thing ultimately in the long run, so that our solutions can actually be tailored to different settings.
Thank you. Do either of you have any additional comments?
Just want to comment just briefly about the data for the minority. And we may not be even developing our own AI, but I think it's important to have that data for everybody in the province. So when we are about to embark on implementing an AI system, we can at least test to see whether the past data, whether this AI system work for everybody equally. I think that's one of the really important part, and then highlights the point that Angel made about having a good data for everybody. Thank you.
I just want to emphasize the same thing, just the opportunity that's there, that AI may not be perfect, but it's better than nothing. Like Angel made an observation, and it's becoming better than humans in some domains as well. So it's the combination of all these technologies that are really exciting, between the computers, between the high-speed internet, between you can be on a Zoom call with somebody, you can have apps on your phone, and now you can have AI assist. All that together is making for an opportunity on having personalized healthcare that we kind of dreamed about. We're getting closer to that all the time. It's just how are we going to actually manifest that and deploy that and accept that as people? Thanks.
Thank you. So we have a few minutes now for questions from the audience, both in person, online, and in Vancouver. We're using the Slido platform, and so there's on the screen the QR code to get into the platform, and looks like there's already some questions in there. I'm going to look at them on my phone. And so the first question, I think I'm going to address it to Angel. I think this is mostly in your domain. The question is, currently there are no regulations for AI in Canada. Where do you see us moving toward with regard to regulation?
So I don't know if there are no regulations in Canada. There's certainly, I think, jurisdictional AI policy frameworks. I know BC has one for healthcare. And really, I think when it comes to these frameworks, it's more about, here are the principles of how you should use it responsibly. Here are the places you should use it on, and here are the places you should avoid. And here are some of the governance structures and frameworks you need to have before you go ahead and just, use AI wherever in healthcare. And I think that's definitely already available in every province for healthcare. What's not available is, I think, if you mean by that, when you talk about regulations, the accountability. If something were to go wrong, the sort of like the stick, if you didn't follow the principles or if you used AI irresponsibly, what are the consequences of that? You're right. There is no, there's no policing happening. But I actually don't think you need to do that. In healthcare, there we have our sort of professional practice compliance regulations that keep us in check. And I think so far that has definitely been a really good source of compliance from an AI standpoint. So I'm not really that worried about additional regulations.
Anyone else want to add to that? Thank you, Angel. I'm going to address the next question to perhaps Raymond. It's, how do we develop trust amongst stakeholders that a chosen LLM, and I'm guessing that's the living language model, large language model, thank you, is providing accurate data and clinical recommendations?
So the question is about trust, and it relates to what Rasika was saying about explainability. You trust as a human for a variety of reasons. You trust a person after you have multiple interactions with that person that's been successful. You trust a technology after you've had interactions with that technology that has been successful. So one of the ways as humans we build trust is to experience a technology, experience a person, and have positive feelings towards that, and that's what we get trust. We also can have trust at the systems level, as Rasika says, if the system explains exactly what it did. And then if you can follow along, you have an understanding on what it has done. So I guess the short answer is, one of the ways to get trust in a system is to experience the system having positive interactions. If it's explainable, that's better. But many of our systems in AI are not explainable. And so once again, just like trusting a human, we trust based on our experience that we have with it.
I do have actually comment on the question, particularly about LLM, the large language models. It goes basically towards the discussion I had earlier about the comment I made about the large companies making inroads to this. First, two things. I have used this example. Some people may have heard about it. If you want to cross Fraser River, if you are in Vancouver, or if you want to cross Okanagan Lake, would you ever consider a cruise ship to cross? Would you ever consider that? In a nice sunny day, it's a calm day, you cross the Fraser River, you may even use a paddle boat, or even in here, it will be a little bit harder, but that's what you would use. Why would you ever? But if you want to take 5,000 people into the middle of the ocean for 10 days and party, then you use a cruise ship, right? So LLM, that's the analogy I would use for LLM. LLMs are trained for large amount of data, do all kinds of stuff, but it can do a specific job very clearly. It's almost like you use a cruise ship, but it won't land where you want to land. You have to land somewhere else and walk back. So that's what basically what I consider is as the prompt engineering. So there's a word that you may have heard, that prompt engineering. You have to, keep asking the thing more and more. I mean, that's, you don't accept that from a car, right? If you accelerate certain amount, you know what the car goes. And the next time, if it doesn't do, you have to tell the car, okay, accelerate a little bit more or less. Are you going to buy that car? No, right? So why would you do that with the AI models? So that's how I see when it comes to these things, the large language model may not necessarily be the answer. The small models that are targeted, specifically trained for given task is the way to go. And that goes along with what I mentioned about these, the big tech companies, because only big tech companies can develop and train large language models. Nobody else can do it. So I think, this all for me make very clear that we need to democratize and then be mindful about some of these big things that are coming at us and resist them because they are not very good. Sorry about that interruption, but I had to tell my feeling about LLMs.
Absolutely relevant. Thank you. I'm going to, oops, want me to ask questions. The next one is about risks of inequities. And the question is, there are risks of further perpetuating inequities by relying on AI models built on inequitable data. And how can we address this? I think some of you addressed this already in discussion of how we could acquire more data and be more targeted in our acquisition of data. Does anyone have any additional comments to add to that one?
I think the first step is recognition that there will be some biases in the models because it's only as good as the data it's trained on. And if you don't have a good enough sample size of the population you're applying the model on, obviously there's going to be, you have to exercise caution. And the only way around that is I think you can adjust. My understanding, I'm not a technical person on AI, but I learned from Rasika that you can actually adjust and calibrate the model to adjust for those potential anticipated biases. And the best is to prevent. And so, continuously incorporate, the data from the minority groups, underrepresented groups, very similar to when we have clinical trials and guidelines in healthcare delivery. A drug or a procedure is not tested on the most heterogeneous population. There is an emphasis to incorporate nuances in the interpretation of the data from a trial or a study. And there's also emphasis to deliberately include minority groups in all future studies.
Thank you. There are a few questions in here that I'm going to paraphrase into data security and the concerns about risk of personal healthcare information, data leaks, insurance companies, the correlation between more use of data, more availability of data with use of AI. Maybe some of our technical folks have an answer to that question.
I can try to tackle how I deal with that. And I mean, as you mentioned, we all agree that healthcare data is very precious. We have to protect them. So I do collaborate with other organizations, academic and industrial. And in none of my projects, I work with them and give them our data. My philosophy has always been that if you want to work in our data, I will give you access to our data. I don't know whether you are familiar with the POP Data BC system. And you can get the POP Data BC to actually get all kinds of data you want. It might take some time, but once they get the data, you have to go to their system and then work there. And data is well protected. So you guarantee. And I think it's very important that we try to not to give our data to outsiders. It's a very important. There was another story about computer company about this, but I want to bring now what is happening with the 23andMe. Right? So original company, yes, it has good policies, but things change, things will go under. If things are got sold under fire sale, there is no rules after that for that data that you gave it to them. So that's why I strongly believe that our healthcare data should be contained within Canada, within the healthcare system, but that doesn't necessarily say that we are not sharing it with other people. They are welcome to use them and develop methodology because they may have better talent than us, but they don't get a copy of the data. They come to us and work with us. So that would be my strong opinion about that one.
Yeah, I just want to emphasize Rasika's point. As soon as you put your data out on the cloud or you send it to any of these AI LLM providers that are a corporation, they may have their terms of use, but still you don't have a necessary guarantee where that data has now went. So I think in the healthcare context, it's especially important to have those AI LLM development done within BC, hosted in BC technologies, or at least Canadian technologies. So you have a verification on where that data is, and it's always private and protected. You can work with companies, but as Rasika says, really this is a chance for BC and the healthcare system to be a leader by developing their own systems and keeping the data in-house. That's better for everyone.
Thank you. Can I end with one last question, which is a question about how to avoid Angel's biggest fear, which is that physicians lose their clinical knowledge since they depend so much on AI. You want to start?
Yeah, okay. So I have thought a lot about this. You know, I'm also a professor, so I do a lot of teaching, and I hate it when I used to hear from my professors the phrase, you know, when I was going through training or back in my day, and now I find I'm using it with my students, and so the key is, you know, I'm a proponent of a balanced approach. It's not that we should, you know, not embrace the new technology. It's not that we shouldn't rely on technology that makes us better, more efficient, and maybe even more accurate. But we just have to come up with different ways to train our students. And the biggest thing, I think, the emphasis is, yes, we have to figure out ways so they can still have the domain knowledge, but we also have to maybe emphasize more on the human-computer interaction, which was mentioned earlier. The interface between the clinician and the technology, and understand that every clinician will have a different AI output depending on how they interact with the technology, and that variability needs to be recognized and cautioned. I think training people on understanding AI and its accuracies, its inaccuracies, its biases, how it generates output is the first step. The second step is, you know, I think there is still quite a bit of confidence I have that the science of medicine is not going to be taken away. There will still be, you know, a lot of teaching, didactic teaching on the science of medicine that will not be given up all at once right away. And maybe there, at the end of the day, it's a balance, just kind of like when residents tell me, you know, I only work a 40-hour work week. I don't need to do what you used to do, which is like work like hell and have a 100-hour work week. I'm going to last longer. I don't need to memorize everything like you did, but I know how to get the information if I do. And so they are trained to be much more resourceful. They have a more balanced lifestyle, and they don't have to go through all of the way I learned medicine when I was going through. And so it's a new style of learning, new style of training people. And hopefully at the end, you know, the combination of a human and an AI together will be better than the most perfect human, no matter how much knowledge they have.
Thank you. I think we're out of time. So I'd just like to really take a moment to thank our panel of experts for sharing your perspectives. This has been really enlightening, and there are so many exciting opportunities that I hope we seize. And I also hope that the biggest fears are not realized, but I really think we have a lot of potential. So thank you very much.
I'll move over behind you to find the camera. So I'm sorry, but I do want to thank all of the panelists as well. So thank you. It was very thought-provoking and really informative. And I think if you look at the individuals and their skill sets, and their backgrounds. It was interesting that they were speaking from different perspectives, but all coming to really speak about AI within healthcare as well. So thank you for that. We now can transition for the next 20 minutes for a coffee break. In both Vancouver and within Kelowna, there will be concurrent sessions both here and in the Skeena room as well. And then coming back all together for a plenary, which will be broadcast from Vancouver to this site at 3:10 as well. So thank you very much, panel, and for all your time and insight as well. So thank you.